I'll now ask Dr. VATSAL Parekh, who has the device which combines both ultrawide field imaging and ultrawide field OCT to give his talk.
Good morning. I thank AIOC and Dr. Nitin Prabhudesai to share my experience with this technology of Silverstone machine, which has what you have in Daytona, like ultra wide field imaging with autofluorescence, with ultra wide field FFA ICG, and image guided swab source OCT. Now, normal OCTs which we all are using are spectral domain, and this is a swab source OCT. The beauty of this machine is that it is image guided OCT. So wherever your image is located on the ultra wide field view, you can get OCT of that area, and it is a swab source. So I'll show you how we have used it in clinical application and how it has been useful. I have no financial interest in this machine. So basically, this is a useful adjunct in retinal armamentarium. It's not a must, but it's a valuable tool. I'll take you through some of the cases to show how it has been useful in improving patient care. Now, this is the first photograph. This is a slit lamp photograph of a one-eyed patient with corneal opacity. You can see the cornea is quite hazy. This slit lamp biomicroscopy, you can see that probably there is optic disc here. But on ultra wide field photograph, you can see the optic disc. And beauty of this swab source imaging is that it gives you a reasonable idea that macula is good. I think with swab source technology, this is possible. So this is a valuable tool to give a reasonably good prognosis to this patient, provided you think your graft is going to do well. So I think this is a wonderful technology. Now this is a patient of proliferative diabetic retinopathy with a fibrovascular membrane here. This is a magnified view. What Dr. Sharath showed pictures of comparison of uh, Heidelberg 30-degree with Optos wide angle photograph. I think there is a difference with Heidelberg because it captures only 30-degree. But if you enlarge the Optos image, you would see the difference to be narrowed down, because magnification factor in your images were different. So what I'm showing you in this is a wide field photograph, ultra wide field photograph, where you see only this much proliferation. But if you magnify, you see it much better. So now how this OCT has helped is here you can do OCT through this region. Now since this is quite elevated from retina, this is the retina base RP and choroid layer, and this is the superficial part of retina, which you see inverted image, and this is the membrane here, which you can see the difference in this and this layer. So this membrane is tightly adherent here. So you can understand the plane of cleavage, and this is the vitreous attachment to this membrane here. Same patient, this is this little different area, so you can see pre-operatively how difficult it would be to dissect this membrane. And the same patient post-operative, there was a hole here because the membrane was quite attached, but rest of retina is nicely attached and patient has been benefited by surgery. So is this tool a must? Not necessarily, because you can see the same things on table. There is something called intraoperative OCT also, but I think compared to intraoperative OCT, this swab source would be much better penetration. Because right now what Zeiss gives is intraoperative OCT, which is spectral domain. So this I think would be a better evaluation pre-operative. Similarly, this is another patient of diabetic retinopathy. You can see that there are a lot of vessels here now. A beginner would confuse whether these are retinal vessels or these are new vessels, but these were new vessels. This is following eccentric injection. You can see that the new vessels have beautifully disappeared. Now again, I'm showing you ultra wide field image, which is magnified, so resolution is still good, because this is a magnified view of the area of interest. Now, when you do OCT, you realize that the retina is somewhere here, and this is the membrane what you are seeing, and not retina. And I'll just show you a short clip of surgery, and it again reveals that this is the retina. This is the membrane what you are seeing. It's thicker than the retina here. So this is what membrane you are seeing, and this is the post-op photograph. of the same patient. He had vitreous hemorrhage. This is the optic disc area, and retina is nicely attached, you know. So this again is a useful adjunct in the treatment. Now this is a patient of proliferative diabetic retinopathy with traction on macula. Now this is the extent of membrane what you are seeing here, here, here. So you can do OCT at all levels wherever you want and understand the pathology. Like this photograph would be of this layer. There is a posterior vitreous detachment nicely here. So probably you can start surgery here. Whereas this area it's tightly adherent, so it would be difficult to separate, you know. So this gives you a fairly good idea in the pre-operative planning as to what you are dealing. Here it's quite tightly attached here, you know, this particular area. So this way, I think it's a beautiful technology. You can do it. Now, again, this another patient who had a sort of tabletop or plastered membrane on the retina, and I operated. And again, if you see the OCT here, this OCT, this is the retina and this is the membrane. You can't separate it. Now, when I did operate, there was a large hole and this membrane could not be totally separated. This is the best we could get. And unfortunately, patient developed redetachment, which was likely to be there. So, having pre-op OCT give us an idea as to what we are dealing with, much more than what we saw on table, you know. Another beautiful application of this machine could be you can have a choroidal thickness or chorioretinal thickness from center to periphery up to equator, and you can study it in hyperopia, myopia, and subgroups whatever you want, and have a normative database designed, you know. And since this is a Swapser's OCT, you can see the choroid also very well. Again, this was a patient of nevus or melanoma, and you can see the OCT can be done at different level. This was autofluorescence, and this machine has, now you can enlarge this image and see this much more, you know, than what it was otherwise. This machine has also FFA ICG, which are ultra wide field, so it gives excellent quality of FFA and ICG. Again, you can magnify the image and see the area of interest well. There was mild staining here, and this was choroidal hyperfluorescence, the hypercyanogens there. The next biggest advantage of Swapser's technology I've found is post-op doing OCT through gas-filled eye. This was a macular hole pre-op picture you can see, and this OCT is 3 hours post-op, you know. On the day of surgery, 3 hours post-op, you can see that there's a gas bubble. The fundus view is not clear because there's a gas bubble, but OCT is reasonably clear, and you can see the hole is closing, and day one post-op, the hole was closed. Again, if you see, the fundus photos are not great. You can't make out on any other way except Swapser's that this hole is closed on day one, and this is a week later. Normally, with all our standard machines, we are able to do OCT when the bubble recedes above macula, then we are sure. But this is helpful in almost 70-80% of patients. On day one, you can do OCT of macular hole. Now, this was a patient of macular hole, and there was a peripheral break here, which would have been missed because of the absence of choroidal contrast. But on magnification, you can see the break clearly, and this patient had a small macular hole. So I think this ultra wide field technology helps. Now, this was a young patient with a macular hole and retinitis pigmentosa and abnormal vitreoretinal traction. I did localized vitrectomy, PVD induction, posterior pole, and you can see that eventually the posterior vitreous is getting detached here. So all these things are beautifully demonstrated. This was a case of retinitis. You can see the follow-up very clearly how the retinitis heals, and you can see the vitreous haze also near the retina. And also you can even in patients of choroiditis, because it's Swapser's, you can see the choroidal OCT very well. Now, Coates disease, nobody has probably defined this abnormal vitreoretinal adhesions. This is the area where OCT is taken. So I think this would give us much more insight in many pathologies. Now, this is another beautiful advantage of this machine. I have realized that this was a patient who had vitrectomy for detachment, inferior detachment. Here there was a probable inferior detachment which was picked up by OCT very well, that this retina is little elevated. Now there was an adequate gas fill in this eye, so I gave position to this patient, and the retina got reattached. You can see that the same area, the retina is reattached. So this OCT helps to confirm the detachment, and since the retina reattached, I could do laser, and here this is the post laser. You can see the laser marks all round. So this helped. However, this patient detached after 6 months and had redetachment. So, but it helps to plan your treatment better. Now, again, this shows the natural course of PVR. This was another similar patient with shallow inferior detachment. Now, when you magnify this image, you see the holes here, and you can do the OCT and see confirm the presence of hole. The OCT is done through this area. This is quite peripheral. So I injected little more gas, did cryo, and the patient reattached. However, it redetached, and I thought it was because of the PVR. And if you see here, this is a clinical photograph. There was a PVR membrane which has matured, and OCT shows that membrane has matured. So it helped in operating this patient again and reattaching retina. Now, this is one of the ideal case I would feel where OCT has helped. This was a horseshoe tear at ora serrata in a high myope patient whose father had bilateral giant tear operated because of myopia. But OCT done through that region showed that this is not a horseshoe tear, but this is an enclosed oral bay. And I think this was $1 million, though anyone would do laser, nothing may go wrong. But here, this OCT, which has gone through ora serrata, helped us to detect that this is not a hole, but this is an enclosed oral bay. You can do OCT of many pathologies like white without pressure, lattice degeneration, and you'll have vitreoretinal adhesions, retinal thinning here. So this lattice degeneration here. Now, why this is important is sometimes these lattices are little posterior to equator. You can't indent and see whether there is hole or not. You can do slit lamp biomicroscopy, still you may not be 100% sure, but this OCT will help you to demonstrate hole if it is there. This is a subclinical RD, how it would appear. And this is a peripheral tractional detachment. You can see the traction here. So I think this technology is very good since this is SWAPSOS, it has better penetration than spectral domain OCT. Since this is image guided and SWAPSOS you can do through gas filled eye and anywhere up to equator, it allows you to understand pathology of the disease process much more. And I think this technology will help us to uncover the undiscovered lesions. Thank you for your patient hearing. Thank you.